So without further ado, let's start talking about radiomics. But before talking about radiomics, we need to talk about cancer. So what is cancer? Cancer is a disease that is affecting our bodies. According to this study, cancer is affecting 1 in 2 for men and 1 in 3 for women. So this means that each one of us, directly or indirectly, we will be affected by cancer somehow. So maybe you are now asking yourself, so am I likely then to develop cancer? Or imagine the scenario in which a patient has been diagnosed with cancer. The patient might ask himself, what type of cancer do I have? And then imagine the situation in which actually the patient is given a treatment. The patient might ask, is this the optimal drug if you are giving me chemotherapy? And is this the optimal dose if we are going with radiotherapy? And then imagine the final scenario in which a patient has recovered from cancer, so basically cancer has disappeared. So the patient might ask himself, will the cancer return? Will I have it back at some point? So actually nowadays we have the tools to answer these questions. And these tools are called biomarkers. Biomarkers basically collect information from patients. The type of information, it's really different. It could be clinical information, it could be genetic information, molecular information, and so on. And then this information is used to characterize the dynamics and the characteristics of the tumor in order to develop new treatment. And you shouldn't be surprised if I say to you that biomarkers are massively used in the cancer field. They are used for prognosis or screening or to check if a patient is responding to the therapy and so on. So if I want to create a list of all the tools that we can use nowadays to develop biomarkers, we can have cellular information, we can have clinical information, and we can have also genetic information or information extracted by serum. But my question is, what if there is a tool that we are currently using every day in clinical practice that is actually, we are using this tool in a certain way, but what if we use it in a different way in order to get new information? And actually, yes, we have this tool, and it's imaging. So let me ask you the question again. So what if we have medical images that are acquired from scanners that are actually containing some hidden information, or some information that it is not visible with the naked eye? And what if, especially for the oncological field, what if this information can really help us to develop new treatments, new biomarkers, and can really help us to save lives? So before being able to answer these questions, let me actually give you an overview of what oncology is, what cancer is, and also let me talk to you a little bit more about imaging. So oncology first. What is oncology? Oncology basically is the study of cancer. As we said, cancer is a disease that is affecting our bodies, and what happens is basically the shape of the cells in our body begin to change. The shape of the nucleus begin to change, and this is a cascade process. So basically, once it starts, it will start to spreading through your body. And you might have come across the word metastasis. So metastasis basically, it's when you have a cancer in a particular site, for example, lung, and then at some point the cancer will appear somewhere else, for example, in the liver. There are many risks of cancer. We can have genetic risk. For example, if there is a history of cancer cases in a family, probably there is a genetic risk in there. We can also have a risk due to radiation exposure, tobacco use. If we smoke, we are likely to get cancer. And also sunlight exposure, for example, when the radiation actually from the sun. So that's why we need to use a sun cream. But as I said, imaging is a tool that we are currently used in clinical practice. And we use it because this is a tool that is giving us information on what's happening inside the body. We can have different type of information depending on the modality that we are using. For example, we can have anatomical information, and if you had an examination before, probably you have heard about words such as magnetic resonance, computed tomography. Then we can go too much into details with functional imaging. Basically, functional images is giving us information about the physiology. And this type of modality is mainly used for the brain so that we can actually identify parts of the brain that are damaged and not working anymore. And also we have another type of imaging that is the molecular one that is giving information about very specific structures in our body. So we can have genetic information, information about proteins, and information about metabolism. But for this lecture, let's focus just on the first type of, on the first modality, so the anatomical one. So now let's have a look at this number. What do you think this number is referring to? It's a very big number, of course. It's 10. It's a very big number, so it's 10,670,375. So what do you think is referring to? And I can give you some hints. It's not my salary, unfortunately. And I assume also it's not your salary either. It's not the number of assessment I have marked so far during my career as a lecturer. So this number is the number of medical images that have been acquired in England in just 1 year. So imagine how big this number will become if I consider all the medical images acquired in the UK for just 1 year. Or even better, if I consider all the medical images acquired all over the world in just 1 year. So what I'm trying to say here is that imaging is used a lot in oncology. And as I said before, that's because we can get information of what's happening inside the body. And if you don't believe me, this is a table actually that is actually reporting the number of images acquired month by month and divided by imaging modality in just 1 year in England. So now you might say, okay, I got it. Imaging is used a lot in oncology. So, but what actually are we doing with this image? What is the process then? Well, in oncology, the process is the following. So basically, a patient undergoes an examination, then the images are acquired, and then there is an oncologist that is going to outline, so basically is drawing a contour on the region where the tumor is. This process of drawing the region where the tumor is a manual one. It's time-consuming, and it's based on past experience and judgment. Unfortunately, this has a consequence, and the consequence is that, of course, if I ask 10 different oncologists to draw or to outline the contour of the same tumor on the same image, I will get a different result. If you don't believe me, I can give you an example. So if we have a look at the image on the right on the screen, we have two contours, the blue one and the red one. So if I actually think that the blue contour is the correct one, it means that if I give a treatment to the patient, I will probably not consider that region over there, highlighted by the yellow arrows. That region was actually included in the red contour, but not included in the blue contour. And that's because the outlining has been made on past experience and judgment. So which one is right? Which one is the correct one? Which one do I have to actually follow to develop my treatment? The reason of this is that, unfortunately, cancer is characterized by heterogeneity. So there is intertumoral heterogeneity, intratumoral heterogeneity. So what does that mean? So for intertumoral heterogeneity, basically, if I have 3 different patients with cancer in the liver, then if I analyze the characteristics of those tumors, they will be different. And you might say, well, fair enough, you are considering 3 different people, so it's normal that they have the tumor that they have has different characteristics. True, but let's have a look at the intratumoral heterogeneity. So basically, if I have one patient with 2 tumors in the liver in 2 different regions of the liver, the characteristics of those tumors will be different. And it might be that the patient will develop a cancer in the lung that has similar characteristics with one of the 2 tumors in the liver. So what I'm trying to say here is that tumor is characterized by heterogeneity, so it's a process that we cannot predict. And the consequence of this is that we are now moving to a more personalized medicine. So a type of medicine in which we are not giving generalized treatment, but we are developing treatment based on the patients, on the single patient, because we want to get the best outcome out of that. So what I'm trying to say is basically that in the past, what we were doing, we were basically collecting information from a cohort of patients, for example, patients with breast cancer, and then we were developing biomarkers and treatments, and then we were giving the same treatments to all the patients with breast cancer. The consequence of this was, of course, that the treatment was working very well for some patients, it was working fine for other patients, and then it was not working at all for the remaining patients. So this means that generalization in oncology is not working. And now we are moving to a more personalized medicine. So what we do now is basically we collect the information of the single patient, we develop biomarkers based on that patient, and then we get the best outcome because the treatment is tailored for that patient, for the patient. And so, for example, if we want to have a workflow of this process, as you can see, is a loop. Basically, there is the patient, we collect information from the patient, we develop biomarkers, we identify the characteristics of the tumor, and then we develop the treatment, and then we give the treatment to the patient. So as you can see, it's a loop where the patient is the starting point and the ending point. Because, of course, for treatment, patient is the central point of all of it. And then, so now if I say to you again that biomarkers are used massively in oncology, it shouldn't surprise you, because that's how actually we can really identify the characteristics of the tumor. That's how we can really develop personalized treatment for oncological patients. So now you might ask yourself, so how can radiomics help us with this? So before actually really explaining to you what radiomics is, let's have a look at the definition. So this definition has been taken from this paper published a couple of years ago. And in this paper, radiomics has been defined as the conversion of images to higher dimensional data and the subsequent mining of this data for improved decision support. What does that mean? So if you want to try to explain it in a simple way, it means the following. Basically, we are having the image, we are extracting new unseen information, and then we are using this information to develop new biomarkers, new treatments. And this is actually a pipeline of radiomics. This pipeline is containing the 3 basic steps that should always be there for a radiomics pipeline. But if you do a literature review, you might see that there are people have added further steps. But let's say that these are the basic steps that should always be there. So first step, of course, is imaging. We need to have images. So what we do is, of course, to collect the images, and then we ask a radiologist to outline the tumor. And then second step is feature extraction, is the main core of radiomics. So it's the point where we are extracting new unseen information. The type of information that we can extract is very different. It could be very easy information like shape or distribution of gray levels within the tumor, the region of the tumor. But it could be information much more complicated, such as wavelet or tumor texture. And I will give you an example of the type of tumor texture or feature we can extract in the coming slides. And then we have the final step, that is the analysis, in which basically we are combining this new unseen information with clinical and genetic information to develop new biomarkers. So as I said before, I was going to give you an example on the type of information that we can extract with textural features. So here is a list of the most common ones that we actually use. We have the gray level concurrence matrix that relies on pixel pairs. And then we have the gray level run length matrix that relies on runs, basically patterns that we can see in our image. And then we have the gray level sun zone matrix that relies on neighboring pixel with the same gray level. So let me give you an example actually for the gray level concurrence matrix. How can we obtain it? So imagine that we have the image on the left. Usually when we have a medical image, the image is divided in squares, and each square is called pixel, and each pixel is containing a value that is representing the gray level intensity of that region. And as you can see in the image on the screen, for our image, we have basically 5 different levels of intensity. We going from 1 that might be probably black, and going from 1 till 5 that is white. So if I compute the gray level concurrence matrix from this image, this is what I get. How did I get this? Let's have a look at the first pixel in my gray level concurrence matrix. I have a 3 there. So basically this 3 is derived by looking at the combination of intensity levels 1, 1 in my original image. So if we have a look at my original image on the left, I have a combination there, another combination there, and another combination there. And that's how I get the 3. If we keep going and look at the second pixel in my gray level concurrence matrix, I have a 3 again. So now I'm looking at the pixel pair, so the combination, with intensity levels 1 and 2. And if we have a look at my original image, I have a combination there, a combination there, and another combination there. And that's how I get the 3. And then if we keep going, we have one last example. So in this case, I have a 2, and I'm looking at the combination of intensity levels 1 and 3. And in my original image, I have a combination there, and another combination there. Oops, sorry. So this is how actually we obtain the gray level concurrence matrix. And if we keep going, basically we fill completely the gray level concurrence matrix. And probably you also have noticed that I've just looked for combination in the horizontal direction. We can also extract combination in the vertical direction or the diagonal direction. So imagine how much information we can extract. And the information that we can extract is not something that is visible in my original image, because if you look at the original image, you didn't see how many combinations you have for a particular combination of intensity levels. But the great thing of this type of information is that we can also represent it. So on the screen, we see some great example of how we can actually visualize this type of information. And this information can really highlight stuff or regions that are not really visible as something that is happening, but is not really visible in my original image. So now you might say, okay, good, I like Radiomics, it's a powerful tool, but what can I actually do with it? So before closing this lecture, let me give you some example of how we can apply Radiomics in medical imaging. So the first example is the application of Radiomics in esophageal cancer. Actually, this is a work I've published a couple of years ago. So what I did in this project was to, of course, collect the images of patients with cancer in the esophagus, and the esophagus is this structure that we have in our body connected with the stomach. And then following the Radiomics pipeline, I extracted the features. I extracted more or less 300 features, of course, that were describing, for example, the shape, textural features, and so on. And then I arrived to obtain this result. So I don't want to go too much into details with the plot that you see on the screen, but basically I want you to notice that on the plot, we have 3 lines. 2 lines are overlapping with each other, while we have a line that is not overlapping with the other 2. So the line that is not overlapping, I have created that line, also the other 2 lines, with radiomics. The line that is not overlapping is representing the group of patients that are more likely to die of cancer, of esophageal cancer. So radiomic can really tell me, by extracting information from the image, it can really tell me which patient is going to die sooner than the other. And imagine how powerful this information is, because if an oncologist knows that, he might say, okay, I will try then to give to this type of patient maybe a more aggressive treatment rather than giving a treatment that is not really working. Let's have a look at another example. Radiomics in hepatocellular cellular carcinoma, so basically cancer in the liver. So what we have here, it's a work published in 2020. So again, the author of this work followed the pipeline of radiomics. They collected the images of the patients, they outlined the tumor, they extracted the features, so the basic steps that are always there, and they arrived to obtain these results. So these plots are very similar to the one I showed you a moment ago, but in this case, as you can see, these lines are totally separated from each other. And also the 3 lines were obtained by actually using radiomic information. And in this case, radiomics was able to identify patients that were more likely to have the cancer back after surgery. So again, imagine how powerful this information is, because if an oncologist knows that a patient is more likely to have the cancer back after surgery, he might say, okay, instead of wait and see what's happening, I will give this patient a treatment. I will try to do something to prevent the cancer from coming back. And then one last example, we have radiomics in lung cancer. So again, on the left, you see basically the pipeline of radiomics, and again, images, outlining of the tumor, extraction of features, and analysis of the result. And in this case, basically, we got these 2 plots. And again, as you can see, there are 4 lines. 2 ones are overlapping, and the other 2 are not overlapping. And in this case, radiomics was able to predict actually the the response of patients to tumor. So again, imagine how powerful this is, because of course, if an oncology knows that the patient is not responding to chemotherapy, instead of giving chemotherapy and waste time, he might give something else. He might try something else, because remember that in oncology, we don't have time. We don't want to waste time, because time is important. And if we know this information in advance, it can really change how we treat our patients. So yeah, some take-home messages for you before closing this lecture. So I hope I convinced you that radiomics is a cheap and efficient and an invasive way to extract more information from medical images. And of course, radiomics is able to actually identify the characteristics of the tumor, and that's why and produce a new quantitative imaging biomarkers. And due to this, I mean, that's the reason why radiomics has become more and more popular in the imaging research, and especially in precision medicine, because remember, we want to develop new treatments that are tailored for a specific patient rather than a general cohort of patients. And this is the last slide. So basically, I hope you agree with me that now we need really to add imaging among the list of tools that we have in oncology, that we use to create new biomarkers. And it might be that in 10 years' time, the list will be we will add new tools in this list. Tools that actually maybe we are using nowadays in a certain way, but maybe in 10 years' time we will discover that if we look at it from the other way around, or if we use this tool in another way, we can actually get a lot of useful and new information. And with this, I would like to thank you all for listening, and Lee, back to you.
So I wanted to start off by asking, thinking about your journey to this point where you get to work on a field which really does have an impact on saving people's lives. Where did it all start and what really inspired you to follow this path?
Well, let's say that partially I was influenced by my father. And also I've always been passionate about science. I remember that when I was a kid, I was always a little bit of a nerd. And I was passionate about science, but also was passionate about medicine. And I remember I was pretty fascinated about the work my father was doing. And I really remember that he had like a small ECG machine that he was using, and I really wanted to know how that machine was working, how the machine was able to get information from the heart, what was the mechanism out of it. And then I remember that one day my father came to me and said, "Oh, look, there is this new course that is called biomedical engineering that is actually merging together medicine and science. So why don't you try it? Because, it's actually covering the topics that you like." And then I started it, and at the beginning I remember that I didn't find anything that was really interesting for me. And it was just at the end of my third year as a student that I really enjoyed studying medical imaging and medical image processing. And that's when I finally realized, oh, okay, finally I found what I like to do. And then it was like an ongoing process because I basically arrived to work with medical imaging and oncologies after my PhD. So it was like an ongoing process. So no, I didn't know that from the beginning.
But it sounds like your father was a big inspiration to that journey. And we're doing this lecture in celebration of International Women's Day. How important is it for you to have good women role models in the field of science, engineering and technology? How's that sort of shaped your journey?
It was really affecting my journey, especially at the beginning, because I felt I was studying in an environment where I was surrounded by men. Also, my lecturers were all men. So I felt like that was not really the place for me, that I was like in the wrong place with the wrong people. And but then I actually understood that, I can do great things, and also women in general can do great things. And I came across some famous profile, like, for example, Marie Curie. And I know that she is well known for her work in radioactivity, but what really shocked me and impressed me at the same time is that she was able to create a portable X-ray unit 100 years ago, and she used it to help soldiers during the First World War. So how amazing is that? So there's nothing women cannot do. We can do the same thing as men, and we need to have more diversity, and we need, I think, these role models such as Marie Curie or Caroline Haslett. They should be actually be an inspiration for women that want to start a career in science, engineering, and so on.
I completely agree, and they've been good inspirations to me in my career as well. But there is sometimes an enduring image that engineering particularly is very stereotypical, a men's profession. How do we break down those barriers and show that actually it's a really diverse community?
Yeah, we need actually to advertise profile of women such as Marie Curie or other important people that have worked in the engineering field, because it's the proof that, if we are given the possibility, we can do great things. So why don't we try? And if there is someone that has a passion for science or medicine, and go for a career in engineering or in science, and don't feel that is the wrong place for you, go for that and prove them that you can do great things.
We've talked a lot about medical engineering, which is your area of expertise. What exactly is it?
Yeah, so medical engineering actually is a wide field. The two words themselves are basically telling you what it is about. It's the merging of medicine and engineering. But actually, there is a lot of things that you can do with a medical engineering degree. For example, my expertise is in medical image and medical image processing, but you can also, for example, study biomaterials, so being an expert in materials that have been that are developed for tools that are going inside your body, or even you can specialize in electronics and maybe build an MRI machine, or like Marie Curie, an X-ray machine. There is a lot of things that you can do. So if you think about all the tools that are used in medicine, if the tool is somehow related to science, or there is a technology behind it, that's something that a medical engineering, a person with a medical engineering degree can develop. So really, anything related to medicine, if it has a science aspect related to it, that's medical engineering.
And engineering in itself is massively diverse, but it sounds like just within medical engineering, there's enough diversity for anybody to have an interest, whether you be creative or analytical or mathematical.
True.
Yeah, that's great. So what one piece of advice would you give to somebody maybe at school or college, or even an undergraduate engineer who is wanting to specialise in medical engineering?
Just go and try. No, yeah. Of course, I mean, as I said before, if you have a passion for science and you are also interested in medicine, I think medical engineering is the field for you. Or in general, if you are passionate about science, go for engineering and don't be afraid. Don't be afraid to be surrounded by men if you are a girl. And go for it. And if it might be that it doesn't click at the beginning. For me, it clicked actually at the end of my degree. So it took a long journey for me to find what I really like to do. But if you're passionate about that, don't give up, try it, and at some point you will find what you like.
And I think I'd agree in echoing that message of, if you think it's not the diverse place for you, actually engineering's a hugely supportive community, and there are more and more women. Yes. We've got a number on our faculty, so it's certainly a growing area. Thank you for answering my questions. I'm now going to ask if there are any questions from people in the audience or in the live stream. Simon, did you want to ask a question? I'm just going to try and summarise the question for our people on the live stream. So Simon's just asked a really interesting question about, you've identified examples where you're looking at people who have already got tumours. Is there potential for that technique to look at healthy patients to predict tumour growth? Is that to develop cancer? Yeah.
No, not really. And the problem is that, unfortunately, we built information with Radiomics based on patients that have tumour to apply this information for new patients. The only way we can extract or get the answer to the question that you're asking, like predict if someone is developing cancer, is just to use genetic information. So genetic is the only way at the moment that we have to get this type of information. The problem with it is that there are too many risks of cancer. So, I mean, genetic is the only one for which we have a tool that is going to give us information about how likely is this person to develop cancer. For all the other risks, like sunlight exposure or radiation exposure, there is a change in your body that we cannot control, or at least we cannot control yet. It might be that in 10 years' time, we might be able to have other tools that might be able to do that. Yes, it's possible, but unfortunately this is not something that is done in clinical practice because it's expensive, and it might be possible, but it's not done.
Thank you. Really interesting question. If we've no other questions from the live audience, do we have some from the live stream?
We do.
Ooh.
Are you ready?
I am. Are you ready, Concetta?
Always ready.
So, question from the live stream: what do you enjoy most about what you do?
Programming. As I said, I've always been a kind of a nerd, so I really love coding, and I really love the fact that by actually coding, programming, and developing algorithms for oncologists, I can actually somehow save lives. so I can do, let's say, my part in this world. So yeah, I enjoy coding, I enjoy discovering new things, I enjoy try to find the solution for a problem, and cancer is a big problem, and I like try to find, the solution for it.
It's interesting that you mentioned programming and coding there, because when I was watching the presentation, I was thinking, is this medical engineering crossing over into the realms of AI and sort of machine learning and things that people might be familiar with very different disciplines?
Yeah, it is. So especially you mentioned machine learning. For example, machine learning is now massively used in imaging research as well, because if you remember, I mentioned that tumor delineation is the weakest link. So we are trying to substitute the delineation of tumor based on experience and judgment with a machine, so that we actually try to standardize that process. So yeah, medical engineering is overcrossing a lot of other disciplines, electronics, informatics, materials, yeah.
Thank you. Any other questions from the live stream?
Are you trained in medicine?
That's a really good one. Are you trained in medicine?
No. I studied biomedical engineering, but I'm not trained in medicine. I also had some modules in my degree that were covering specific parts of a degree in medicine, but no, I'm not trained in medicine.
And it strikes me that medical engineering is a really good way to get into the medical field without having that medical degree, that long sort of training in a medical background.
Yeah, because for example, especially in our course here at the University of Huddersfield, we will also give students the opportunity to study modules such as anatomy or physiology, so that they will have like a basic knowledge of the physiology and the anatomy of the body, because that's the thing that they have to use to develop new stuff. So it's important that they have a little bit of background in this.
Great. Any other? Oh, we have some more. Excellent.
What do you recommend school-age students can do to help learn more about future careers in science and engineering?
So that's a good one, and something I might pick up on in a little while. But for you, what can children at school do to learn more about these fields and careers in science and engineering?
Oh, well, try to look for important people that have done a lot of things in this field, because they might inspire you. And if you are, as I said before, if you are passionate about science, just go with the career inside or in engineering, because, I mean, you will learn stuff you enjoy. So, yeah, just go for it.
Just go for it.
Yes, go for it.
Definitely.